Hi, sir. Good evening. Welcome to the
Hi.
podcast.
Hello,
How are you, sir?
Samir. I'm good, good.
So,
Thank you for having me here this evening.
it's an honor, sir, for me to have you here. Um, bef- uh, Before we begin into the delve into the depths of endocrinology, I want to keep this topic focused more on diabetes and diabetes management. For our viewers, could you just explain the different types of diabetes that people should be aware about?
Actually, if you look at diabetes, basically, let me explain why diabetes occurs and then let's talk about the types of diabetes. Usually, what happens is whenever we have our food, whenever we eat our food, that gets converted into glucose in our body, and this glucose is transported through the blood vessels, through the blood to all the different parts of the body, and it is used as fuel. So whatever we eat gets converted into glucose. It goes from blood to the different cells of the body, and these cells have to take up that glucose to use it as a fuel. And to
Right.
take this glucose up inside the cell, we need a hormone called insulin, which is produced from the pancreas, the beta cells of the islets of Langerhans, as we call. And so what happens is normally when we eat, glucose is produced, it goes in the blood and it is taken up by the peripheral cells with the help of insulin, and it is used as fuel. Now this process is very fine-tuned and the blood level of glucose is maintained within a normal range.
Right, sir.
So when a problem happens with either the production of insulin, secretion of insulin, or when insulin is secreted, produced in normal quantities, but it doesn't work properly at the peripheral cell level. And because of these two reasons, the blood level of glucose starts going up and then the diabetes develops. So the reason for diabetes is either insulin deficiency or insulin resistance. In here, so basically diabetes is, when you look at the classification, it is typically classified into type 1, which is seen in children, which is because of insulin deficiency, because of a problem with the insulin producing cells, and type 2 diabetes, which is because of insulin resistance, where insulin is produced but that is not able to work properly at the peripheral cells. Now, apart from this, there are other types of diabetes which are recognized. Its third type is known as
Gestational
gestational
diabetes.
diabetes which is they're seen in diagnosed during pregnancy in women, and the fourth type is called secondary diabetes.
Right.
Now, secondary diabetes is the one which is produced because of other reasons, other medical problems, other hormonal problems, which can cause like steroid-related issues.
Most common would be steroid-related, I guess. Right.
Steroid-related Cushing's, or there could be certain drugs
Right.
which may be responsible for secondary diabetes. So these are basically the four types, predominantly being type 1 and type 2. That is one where insulin is not produced, and second where insulin is produced, but there is a resistance to insulin.
Then, could you please explain to us how come India has become the diabetes capital of the world, sir?
Yeah, India has that dubious distinction of being called as the.
That's not a good thing, actually.
Yeah, actually, I wouldn't want my country to be number one here. In other good fields, sports and all is fine, but not to be called as diabetes capital of the
Definitely.
world. But the reason why things have, why diabetes has increased in our country, it's manifold. And the most important reason is lifestyle change. But there are genetic reasons also behind this. And if you look at the evolution, specifically in our Indian subcontinent, in our country, if you look at the history of civilization in our country, earlier there are lots of famines and droughts and scarcity of food in our country. And that's why our metabolism was programmed to store energy. So whatever our ancestors during these drought and famine situation they would eat, that would be stored by the body.
In the form of proteins,
In
probably
the form of fat,
fats,
predominantly, and storage stored as energy. And over a period of years, that is decades and centuries, the food scarcity which was there decades back or maybe centuries ago has now changed into a situation where there is abundance of calorie-rich food.
Right.
So that's why this is called the thrifty gene hypothesis, where
Okay.
like we Indians have developed that thrifty gene because our ancestors came from a situation where there was food scarcity. So whatever was there would be stored. So we carry the same genes, and now we have food in plenty and a lot of high rich food. So whenever that is consumed genetically, we are programmed to store that. And that's the reason why the incidence of obesity is increased. And there is a significant change in lifestyle. So it's always said that genetics load the gun, but the trigger is pulled by the environmental factors.
What a lovely statement.
So we do have evolved into having these genes which are detrimental for us. But when the environmental factors contribute to it, which includes unhealthy lifestyle where lack of exercise, unhealthy food, in that situation, the obesity center, typically when you see we Indians, it is a central obesity. The abdominal obesity is more. In that situation, the risk of diabetes increases significantly. So change in lifestyle where lack of exercise, unhealthy food, even things like stress. If you look at the overall life or day-to-day life of an average Indian, it's become much more stressful than whatever grandparents lived.
Definitely.
So I think that plays a significant role.
But sir, is the diabetes only seen in urban areas, or do you see in rural areas as well?
There's a tremendous
because lifestyle, you said.
Oh yes, but if you look at the rural lifestyle also, it's changed tremendously. I mean,
Right.
you go to the rural area and see majority of the rural households would be having a two-wheeler, a motorcycle.
Oh, correct.
And the younger generation, if you see, would be the level of physical exercise which was being done in rural India earlier, that has also gone down significantly. So definitely lifestyle has changed, and there is urbanization. If you look at our own city, Nagpur, the city has expanded
so much right.
that the so-called rural areas which were around Nagpur are within the city.
Exactly.
So those people who lived in those rural areas now
are the part of the urban areas, right? Very true.
Of the city.
So, sir, the next question comes: how does an endocrinologist help in controlling? Let's say talk about diabetes for today.
Yeah, actually, endocrinologists do play a significant role, and basically in various ways you can contribute. Apart from treating the patients with diabetes, when they come to you, I personally feel, and I always say that when the patient comes to you, it's already late. He has already developed the problem. You should try to prevent the problem before it occurs. So one very important thing is educating the public, and I think you are doing a great job of having this session where awareness of the public would increase about diabetes. Similarly, various sessions are there, and now with digital media, there is a lot of information available about diabetes. So people should be made aware about this. Even other doctors, specialties, general practitioners, physicians do contribute significantly to the awareness. All the medical community has to pitch in terms of diabetes awareness. Another important thing I feel, and which I try to do in my practices, whenever the patient comes for consultation, I always ask them, how many kids do you have? How old are they? Do they exercise regularly? Do they have a healthy lifestyle? If no, then please inform your children that they are at a higher risk.
Right.
So making them aware about, or if many times so happens is the parents, the children would accompany their diabetic parents, and at that time you sort of try to educate them about the importance of healthy lifestyle.
Right. So, sir, in your practice of so many years, could you share some insights into the psychological and social aspects of diabetes management that you have come across?
Yeah, I think that plays a very, very important role. These psychological aspects are few because, few important ones. Where, if you see, before the development of diabetes, people are just carefree. I mean, if you look at the younger generation.
I'm an example.
No, I wouldn't say that for you because you are aware of. And as I said, there are certain things which are genetic, so you can't help certain things. But if you, as we were talking earlier, you do have a healthy lifestyle, so regular exercise, following things, that helps. but there are people who are not aware of these things. So what we have seen is before the development of diabetes, people are very casual. Once the diabetes develops, they are shattered. Sometimes they're very scared. There is a phase of denial initially.
Fear psychosis and all happens?
Fear
Does
is
it go
there
that
initially in
extreme?
some people, and then they start listening to things. They start listening to the advice, and then over a period of time, they get used to it, and again they become casual. So that should not happen. What we have seen, as you're asking about the social aspect, what I have seen over a period of these years is we are seeing much younger population in the clinic with diabetes as compared to what we used to see 20-25 years
What
back.
are the youngest patients you're seeing right now? What age groups are?
Actually, as you say, type 1 diabetes is seen in children,
Definitely.
but type 2
Type 2,
diabetes,
right.
which is increasing in children, I think the youngest I have is around, I think 10 years of age, who has type 2 diabetes.
But what was the reason when you poked deep into
Same
it?
thing. I mean, there are strong family history.
Right.
They had a strong family history, both maternal as well as paternal side. There is a strong family history of type 2 diabetes. The mother had gestational diabetes during that girl's pregnancy, so that is a very high risk factor.
Right.
The birth weight of that child was high, so that predisposes and unhealthy lifestyle. I mean, these children are glued to TV or mobile. They don't play.
Physical activity, lack of physical
activity is
right.
low. Fast food.
Right.
You'd love chocolates. You'd have fast food, and no exercise. So with all that, the diabetes develops at a younger age.
So, what are the most biggest challenges you face while managing patients with diabetes, sir? I mean, compliance, I'm sure, must be an issue with medications. What more issues do you get,
Compliance is a major issue, and I think that awareness needs to be increased in the patients and the families that if they're compliant with the treatment, they are going to be more healthy in terms of having a better control and having lesser risk of diabetes related complications in future. So compliance is a major issue. Other challenges that we would see specifically in our country are certain things earlier over a period of time that we have seen now that availability of modalities for monitoring and diagnosis are available in majority of the places. When people come from remote areas, their availability of good labs is a challenge when they come from remote areas. In our country, majority of the patients are self-pay patients. So they have to
pay out of their own
pay
pocket.
for their
No
own
insurance.
medicine.
Right,
There is no insurance which covers for outpatient medicine. They may have insurance, but it covers for the admitted
IPD only and no
stay,
OPD. Right.
but not during OPD. So majority of them are self-pay patients. So affordability is an issue in good number of patients. And that's the reason why when we as clinicians prescribe medicines, we have to be conscious about that fact also, about how and what medicines we prescribe for the patients. Because they should be able to afford it and they should be taking it on a long-term basis.
So definitely, sir, during diagnosis and management, somewhere you have to, do you have to keep in mind the economic profile of the patient as well?
Oh yes. Definitely we need to be aware of the economic profile of the patients and tell them. And also another thing which I want to highlight here is nowadays diabetes is so much prevalent everywhere. There are a lot of people who are promoting certain unheard therapies for diabetes.
Not even alternate therapies, unheard therapies.
Like I had a patient who said to me that मुझे ये जो पत्थरों की माला पहनाई है डॉक्टर ने बोला कि ये आप 6 महीने पहले पहनो इससे diabetes nikal jayegi. So he was wearing a neck, something like a mala on his neck and a bracelet, and he was sold that for few thousands of rupees and was told कि इससे diabetes nikal jayega.
हमारे पास sir, I mean, in my ophthalmopedy, a patient walks in wearing a very weird kind of an ear stud. it really pokes out. You can tell कि this is not for jewelry purpose. And I asked this lady, आपने क्यों पहना है? I mean, what is the significance? Does it have some religious significance? क्या है? She said, मला sugar होती. Some fellow said कि I'll punch this
Yeah.
ring into your ear and your sugars will go down. And she said, पहले मैं insulin पीती and now I'm not on insulin. I have my blood report to prove. And this guy charges 40,000 rupees for piercing. What nonsense!
Yeah, I mean, I have a patient from Madhya Pradesh whom I tried to convince, but he wasn't convinced. He's a rich man, doesn't have problem with money. He goes to Mumbai, and there he said every month he goes, he's given some injection, and he has been told that this is stem cell injection. And ये injections हम आपको 8-10 इंजेक्शन लगाएंगे और स्टेम सेल के इंजेक्शन है, ये इंजेक्शन लगाने के बाद आपकी डायबिटीज चली जाएगी.
This is a small course and lifelong खत्म ऐसा kind of
हाँ.
रहेगा. My
And for
goodness.
every injection, he's charged some, I think something like 50,000 or 60,000. He and his son go there. So I told him there's nothing like this therapy where every month you go and take stem cell injection.
हाँ, होता तो I would have given it in my hospital,
So
right?
वो बोलता है कि नहीं साहब, उसने तो बोला इससे डायबिटीज से
Like,
और वो he says कि सर मुझे पैसे का तो प्रॉब्लम नहीं. बोला यार तुम्हारे पास पैसा है इसका मतलब ये नहीं कि you do
कुछ
things.
भी
At
करो
least
ना,
it's
yeah.
my job to guide you properly. There's
Right.
nothing like this which you should be doing, but people are.
So coming back to the old debate, sir, um, generic medications versus branded medication. Do you see a difference in the efficacy of the medications? Have you observed anything?
Actually speaking, if the generic medicines come from a good pharma industry, it is efficacious.
Okay.
Problem is regarding the drugs which are made by companies which are not reliable, which do not follow standard procedures for making these drugs, where the quality is not guaranteed. So there is the problem. I do agree and I feel generic medicines are required, but it needs a good quality control. Every Tom, Dick and Harry comes with a generic medicine.
Exactly.
And you find that even if the patient is taking the same company medicine, he buys another stock, the glycemic control changes. So there is a time where it becomes difficult to control. So I think there has to be good quality control, and I personally think now the government of India has certain policies regarding control over the quality of generic medicines, but still we need to, there
Under
are
the
some
radar
companies,
कुछ ना कुछ
there are
चलता ही
certain
होगा,
companies
right.
where we really don't know the quality. But good quality generics are the ones which are actually the need of the hour. If you see the history of pharma industry or looking at certain medical conditions, for example, tuberculosis or HIV. If you look at the tuberculosis drugs or HIV drugs, when they came in the market first, they were very, very expensive.
Right.
But looking at the public health issue,
Subsidy
the government
was
of
given.
India made it a point to bring these medicines at an affordable cost, and
We
it's
still have
being-
a TV program going
exactly.
on.
And these, even HIV today,
HIV,
I think
right,
is
right,
World HIV Day, and we know that during with the increased incidence of HIV and all, the HIV drugs have been made available in government hospitals for people, and they're available for free in some of the places.
Right.
So I think diabetes, the proportion of diabetes that we see in our country is huge, and there has to be proper program for treating, evaluating and managing diabetic patients. And frankly, we need to have good diabetes care in government setups. For
That is where the major load of patients do
who are
come up.
not affording,
Right.
for people, because many of my patients who are not affording, I used to refer them to the government colleges for diabetes OPDs, especially the type 1s who would get insulin there. But they used to tell sometimes we go there and it's not available. We had to stand in line for hours together, और वहाँ काउंटर पे पहुंचने के बाद पता चलता था कि इंसुलिन है नहीं, फिर बाहर से तो लेना ही पड़ता है.
During our medical training and residency, sir, हमको एक बहुत common point सुनने को मिलता था. Pilferage बहुत होता है from government hospitals and centers. I mean वहीं का staff is taking it away somewhere. I don't know if they've controlled it over the years right now. But
I'm not aware, but I think we have a good network of government hospitals, but a very casual way of working where people are not answerable, or rather,
There's no accountability.
there is no accountability. Absolutely.
Right.
So we need to develop a system where it reaches to the deserving people, to the population, to the patients who really deserve. Because many times they go there and they find, and pilferage is a big issue. I think it depends tremendously. There has to be proper audits. I'm sure there are institutions,
Right.
there are standard operating procedures for all these things, which I'm not aware about the details, but I'm sure they are there. But they need to be adhered to, followed, and there have to be proper audits in terms of all these things. We know that there is a huge public health program for non-communicable diseases started by Government of India for in diabetes also. So in that, there are many things which are there for which government is taking care of, but it needs to be implemented properly, and the patient should be benefited. It needs to be monitored properly.
So, moving on to the next segment, sir. What newer modalities of diabetes management and care have arrived in the past few years? Could you please enlighten us? Also, let's talk about the new wonder drug going around, Ozempic or Semaglutide, as it is being sold in India. Please enlighten us.
Yeah, regarding the diabetes management, it has changed tremendously over maybe last 2 decades. Let's split it into few things. Like, first is about the diagnosis, second is about the monitoring or management, and third is about the treatment. So regarding the diagnosis of diabetes, now the facility for checking blood sugars is available at smaller places also. Earlier we knew, I remember when we were doing our post-graduation.
What year was that, sir?
That was 1988.
I was born then.
1989 to 1992 was my MD. So during that time, we used to, in our ward side room for house officers, in the house officers room, we had a ward side laboratory where we were supposed to look at the peripheral smears ourselves. We were supposed to do urine ketone. We were and blood urine sugar by Benedict's and monitor all this Rothra's method and all those. I still remember we had to do those things. Checking blood sugar in the ward was not possible because glucometers were not there then. They were there, but they were not freely available. They were not available in the wards.
Definitely.
So we had to do urine sugar monitoring. Urine ketones were checked by chemical methods, where we used to have that test tubes and heat it on the flame and all that. But the things have changed now. Now there are simpler methods for monitoring. Glucometers are available. People in rural areas also, and they have become affordable, reasonably affordable now. So the monitoring modalities are available even in rural areas. Facilities for laboratories are also available in smaller places.
I think the penetration has been good.
Penetration has been good in that terms. Second thing is, this is about the diagnosis. About the monitoring, as I said, glucometers are available. And now when you talk about the newer modalities, now there is something called continuous glucose monitoring system, CGM, where you just put a small sensor on the arm and it continuously records the blood sugar.
How many days one device lasts, sir?
That sensor lasts for 14 days.
14 days. Usually. And then you replace it.
Yeah, and now in that also there is an advancement. Earlier it used to be just, it would come with a reader and you had to read with that reader. It was like a mobile device. Now
you can do it with your own mobile nowadays, I guess.
Now you can do it with your own mobile, and there is a software with which it is linked to the doctor's mobile.
Oh, lovely.
So if I have a patient who has put on a sensor, CGM sensor, I can in real time see what my patient's sugars are anywhere he is. Yeah, so it can be monitored.
So would you get a spike or a notification कि मेरा ये patient
you just go to that app. You download that app, you download the patient's and you go to the patient's thing, it will show you what the patient
No. My question is, let's say you are in your OPD and you are...
No, it doesn't give me an...
कि इसका एकदम से rise हो रहा है, like emergency type of situation.
ऐसा नहीं है, but if whatever time I want to, I can
that you can definitely
set You can set these things if
Right.
you want for a particular notification.
You have a high risk patient, you
Yeah,
have set
yeah,
his
yeah, you can.
then I should get a notification, and then I would
Right.
ask my assistant to call,
Right.
kya ho gaya, what are you doing?
Right. So those things are possible now from remote. So these are the advances in monitoring. Regarding the treatment part, the treatment has also evolved tremendously. And when we were doing our post-graduation, the oral drugs which we had were hardly 2 or 3. We had metformin, we had glibenclamide, and glipizide were 2, 3 drugs which we had only. Then even insulins, we had a regular insulin, we had NPH insulin, and we had mixed insulin. And that time insulin use, there were no disposable syringes. They were very expensive. There was a glass syringe which had to be boiled and given that way. So now insulins also, you will see there are a variety of insulins which have come, which are sort of called designer insulins, so that they match with the normal physiological insulin secretion by the body.
Could you please throw some light on designer insulin? What do you mean by that?
See, normally, again, when I talk about designer insulin or whatever, the newer treatment, whenever treatment gets evolved, these treatments are evolved in a way so that it matches your normal healthy body's physiology. So when you look at the normal healthy body's insulin secretion, there is a basal insulin secretion which goes on for 24 hours. Throughout the 24 hours, your beta cells produce a basal level of insulin.
Definitely.
And whenever you eat,
it rises.
It peaks and then comes down over a period of time again to that baseline. But when you give insulin from outside, 2 things. It has to maintain that basal level, and you have to give insulin, short-acting insulins, which we call, which would have the same peak like what is normally produced when you eat. So these newer designer insulins are again divided into 2. They are basal insulins, which give you a basal insulin coverage for 24 hours. These are called peakless insulins. And the newer ultra short acting insulin analogs, as we call them. So when you take them, there is a spike in insulin levels, and over a period of time it comes down. And the time frame during this happens is being done so as to match the normal physiological peaks. So these are the designer insulins which have come. Regarding the oral drugs also, there are many oral drugs which have come now. Newer, what we call as newer sulfonylureas. There are drugs, newer
GLP-1 and
GLP-1 receptor agonists. There are drugs like SGLT2 inhibitors. So these drugs, like for example, SGLT2 inhibitors are the newer drugs. The way they work is they excrete excess of glucose through your urine. So that they excrete the glucose through your urine. But it has also been seen that apart from glucose lowering or blood sugar lowering effect of these drugs have other benefits in terms of cardiac benefits they have shown, in terms of renal benefits they have shown. Similarly, as we are talking about GLP-1 receptor agonists, these are the newer drugs which have come. These are GLP-1 drugs in terms of injectable, like oral also has come. Oral semaglutide is there, and injectable drugs, as you said, Ozempic is the one. It is the injectable form of semaglutide. Only thing is in India it's not yet available, but oral is available in our country. And these drugs, even there are other drugs which work on the same axis as we call as the incretin axis, which are called DPP4 inhibitors. The gliptins, these are the ones which are, but GLP-1 receptor agonists are the ones, again, like the SGLT2 drugs, as I mentioned to you. These GLP-1 receptor agonists have been very clearly shown to have cardiac benefits. So nowadays, when you look at the guidelines for treatment, the treatment guidelines do mention that you look at the patient, whether the patient has cardiac risks or has an established cardiovascular problem. And if the patient has an established cardiovascular problem or cardiovascular risk factors, you should consider GLP-1 receptor agonists. So
a lot of people are using it for weight loss also.
Yes. It is available. It is approved for weight loss also, specifically the injectable one, Ozempic. Even the oral semaglutide has been shown to cause weight loss, and it is being used for weight loss. It does But let me tell you one thing. I mean, it is a drug which helps weight loss. But it is not a drug which people feel that I won't do anything. Let the
हाँ,
drug do everything.
it will exactly.
No,
ऐसा नहीं
you
होता है.
have to have that lifestyle
Definitely.
modification. You have to have proper diet. You have to have a change in lifestyle, proper exercise, and then these drugs would help. Second thing, the amount of weight loss. That is also a thing. There are some patients who have a good, significant weight loss, but on an average, the weight loss is somewhere between 5 to 10% of the baseline weight.
Mm.
So, depending
That's
on the
not a lot,
baseline
right?
weight, it's about 5 to 10%. Some patients do have more than that, and significantly more than that.
Depends
And
on the patient profile.
depends on, but on an average, it is 5 to 10%. But let me tell you one thing: this even 10% weight loss is metabolically beneficial. So 10%, if it's been shown that even if there is a 10% weight loss, it has a benefit in terms of reducing the risk factors or complications of diabetes. So that is a significant weight loss that is achieved.
So, sir, is there any particular division when you do keep newer drugs for such kind of patients and old drugs for those kind of patients, or a mixture of both?
It's usually we need to individualize the treatment, and there are guidelines for this. And if you look at the guidelines, there are international guidelines given by ADA, by American Association of Clinical Endocrinologists, by Endocrine Society of India, and also RSSDI. Now, if you look at the guidelines, AAC and even RSSDI guidelines, they do mention that it's not only the fact that you want to bring down the sugars, you have to consider other things also of the patient. One is the age of the patient, duration of diabetes, presence of comorbidities, even finances of the patient need to be considered. And based on all these factors, you need to decide for a particular patient which drug you would choose. Like as I mentioned to you, when suppose a patient comes and is diagnosed to have diabetes for the first time, he's diagnosed today, and you want to start the medication. Even it depends on what is his baseline blood sugar at the time of diagnosis and what is what we call as HbA1c.
Right.
Glycosylated hemoglobin A1c, which is an average blood sugar for past 3 months. So if the average blood sugar for past 3 months is high, if the baseline blood sugars are high, you may want to, or as per the guidelines, you are required to start with not one drug, maybe dual drug combination, or sometimes triple drug also.
Right.
Sometimes you may have to start insulin right in the beginning. So you need to individualize the treatment, and majority of the times first after diet, exercise, metformin is the drug which is first given, and after that you need to, as I mentioned, you need to categorize your patient based on the cardiovascular risk. If the patient's cardiac risk is, patient is a known established case of cardiovascular disease or has significant risk factors of cardiac or renal, then the drugs like GLP-1 receptor agonists and SGLT2 inhibitors would become the drugs of choice to be started in the beginning.
Would they be the first line of treatment in such a case?
Usually it is after metformin.
Okay.
Of course, in some patients where metformin is not, it's contraindicated, or patient's tolerance to metformin is an issue, in that situation, these could be started before metformin.
Nice. Great, sir. Moving further, sir, let's talk about pre-diabetics. What advice do you give to such patients nowadays?
Yeah, that's a thing which is really very important, and something which
I mean, what can a pre-diabetic person do to stop the progression and go into the non-diabetic zone?
Yeah, there are two things. One is pre-diabetic you're talking about is where the sugars are borderline. They're above the normal range, but below the diabetic range. That is where you would call it pre-diabetes. So in such situations, once they are in that zone, you have to sort of explain to them that you are at that border where you can reverse it or you will progress further. And significantly it depends on your own input in terms of lifestyle modification. So you tell them, inform them, assess their own lifestyle, and it is very important. I'll tell you, majority of us don't have much time in the clinic to spend with the patient.
Definitely.
Because of the volume of patients that we see. But we can develop a system where these things are taken care of. Like for example, in our hospital, what we have done is we have diabetes educators, we have dietitians, diabetes educators, and we have junior doctors who would, like for example, if a patient comes for the first time diagnosed or has borderline blood sugars, as you're saying, pre-diabetes, in them the diabetes educator will sit with the patient, assess the patient in terms of
Give them a
his lifestyle.
good amount of chair time.
Yeah,
Right. They need a lot of time.
and they would document the things that patient has, whether patient is exercising, not exercising, following diet or not, and they would guide the patient. We also in our hospital have an exercise consultant. We have a physiotherapy unit, and for patients, see, many times we ask the patient, "आप exercise करते हो क्या?" They would say, "हाँ करते हैं."
Right.
And you don't stop there. See, आपने बोला, patient ने बोला कि हम exercise करते हैं, and you stop there. Many times you will be surprised what exercise they do. You ask them, क्या exercise करते हो? नहीं सर, हम तो जब ड्यूटी पे रहते हैं तो इधर उधर चढ़ना होता है, जाना होता है. अरे, that's not exercise.
That's not exercise.
You ask certain ladies who are homemakers कि exercise करते हैं, हाँ करते हैं, क्या करते हैं, बच्चे स्कूल में जाने के बाद थोड़ा PT कर लेते हैं. No, that's so. We have an exercise consultant, a physiotherapy unit in our hospital where we send the patients, they are guided as to what are the types of exercises. Like they have to have aerobic exercises for at least 40-45 minutes. They have to have strengthening exercises where muscle strengthening exercise, either they do minimal weights and stretching exercises where yogasan, even there are certain exercises where you use your own body weight for toning up the muscles. So those are all told to the patient. Diet needs to be assessed. You need to take a diet recall from the patient, guide the patient regarding all these things. So that plays an important role in
So, sir,
prediabetes.
can early screening and public health initiatives kind of prevent the burden that people are, by the time your patient comes to you is already in the diabetic range, but if we hold public early screening
Yes.
camps or
Yes.
public health initiatives,
Actually speaking, if you look at it, it is said that you should start diabetes prevention from the womb.
beautiful.
The pregnant lady should have a healthy pregnancy. During pregnancy, the patient should be aware of a healthy lifestyle during pregnancy also. And during pregnancy, she should have a healthy lifestyle. She should eat well. She should have a proper monitoring so that the healthy baby is born. And it has been shown that the healthy weight of the newborn is between 2.5 to 3.5 kgs of weight.
Definitely.
The newborn baby, if he or she is less than 2.5 or more than 3.5 kgs of weight, the risk of metabolic problems in future life are higher. So having a healthy pregnancy and a healthy baby is the first step towards prevention of diabetes. And then it starts with a healthy childhood. Nowadays, we know the children are under tremendous pressure. The lifestyle of the kids have changed. They don't play much. There is no outdoor games
They're
for
all
the
indoors
kids.
nowadays.
They're glued to the digital media,
Right.
to the laptop, to mobile, and to the TV screens. Now, if you, I just heard in the news last week that in Australia they have
They're they're banning social media, but there was so much of protest that they revoked it back.
Yeah, I think it is an important
It's
step.
an important step.
Important step. You don't need a child, a very small child, to get into social media. But of course, the other side is nowadays many of the school assignments are given on the digital media. So the schools have to work on it, where it should be permitted for what activities. So it starts right from there. And regular exercise for the children. I'll tell you, it was I think about 15-20 years back, and I think your mom was also a part of that school education program through Rotary that we did.
Right.
Where we had gone to various schools regarding healthy education, healthy adolescents, and the school health program, where we went and talked to children from 8th to 10th standard in various schools. I had gone to almost, I think, 13-15 schools in
So
Nagpur.
you must have done the sugar and exercise part, My mom did
The physiology.
the
and-
physiology for girls,
Right.
menstrual cycles, and
Right.
my dad did for the boys
Right.
about sexual
Right.
education and all
Yeah.
those
So we
things.
were that group, and there it was. Wherever I went to the schools, there used to be teachers also. So I used to ask the teachers in the schools that when the children come to your class, you ask the children, did you do your homework? Whatever homework you give, you ask them, have you done your homework? How many of you ask the students, have you played yesterday? Do you play regularly? Right? It is an important thing.
It's an important
It is
thing,
an
definitely.
See, good number of schools, you talk to the school children, they would say we have a physical education class. But during the physical education class,
वो दूसरा टीचर आता है, कोर्स खत्म करना है मेरे को,
कुछ तो पढ़ा देता है, या फिर दूसरी कोई टीचर आती है, सॉरी दूसरी कोई टीचर आती है, वो वहां बैठती है और कहती है कि तुमको जो करना है करो, आवाज नहीं करो.
Yes, let me do my work.
Why not leave those children in the playground?
Exactly.
Let them play. That childhood has to be that way.
It has to be enjoyed also.
Physical development also helps in proper emotional and mental development. That is such an important part. Children should live their childhood
carefree.
Absolutely. And both parents as well as schools have to play a role in that. When children come home, उसके बाद उनको कोई ट्यूशन लगाई जाती है.
Yes.
अरे बच्चे को 2 मार्क्स कम मिले तो चलेगा, but let the child be healthy. That is such an important
Very
thing.
true.
I mean, I tell them that you have a brilliant child, but he or she is unhealthy. That is more distressing for you, the child, and also detrimental for the society.
Definitely.
So 2 marks kam mile, but the individual is healthy and happy. That will be much better. So diabetes prevention starts from womb. Healthy childhood. You need to educate the young people about having a. Now we know as school they come to 10th, 12th standard, the education stress increases. When they get into job, there is that pressure of finding a good job. They find a good job, a high-paying job, but it is a highly demanding job. They spend hours and hours together. Especially you see these IT professionals have wonderful packages.
Oh, wonderful packages. Stress levels are too high.
Money. In terms
stress
of
levels
money,
are very high.
Stress levels are high. They spend tremendous amount of time in terms of the screen, and they don't have much time for themselves.
Definitely.
So young adults, you need to educate them, and this will go a long way in prevention of diabetes. I always tell people especially as I told you, my patients and their accompanying children, when they come, I just tell them that whatever you do, take out at least 1 hour for yourself. When they say I don't have time, हमको टाइम नहीं है.
नहीं, टाइम बनाना पड़ता है.
Exactly.
That is how I'm doing this.
Exactly. I just tell them that सभी को 24 घंटे मिलते हैं, आपको भी 24 घंटे मिलते हैं, मुझे भी 24 घंटे मिलते हैं. वो 24 घंटे में क्या फिट करना है,
that's up to you.
So it depends on your priority. If your health is your priority, you will fit that 1 hour of exercise in those 24 hours. If health is not a priority, you won't do it.
Definitely.
So you have to make it a priority, and I think those are the things which need to go a long way in prevention.
Sir, so how do you educate your patients about the complications of diabetes, like renal diseases, or from an ophthalmic side, diabetic retinopathy? How do you go about telling your patients about it?
As I told you, we have diabetes educators in our clinic, and the team, including the diabetes educators, the junior doctors, they tell the patients, and when they come to me, I also tell them that you need to control the diabetes. Usually, first time when they come, when the person is diagnosed with diabetes, you have to judge the patients when they are sitting across. Some patients, if you just tell them कि ये हो सकता है, वो हो सकता है, वो हो सकता है, they are scared, totally
हाँ, वो डर के कुछ भी नहीं करेंगे फिर.
हाँ, so basically आपको individual patients को you have to judge. Sometimes you have to just sort of tell them यार डरो नहीं, अभी तो ये हुआ डायबिटीज बहुत लोगों को होता है, लेकिन आपको कंट्रोल करना जरूरी है. पहले कंट्रोल करो, फिर अपन बाकी की बात करें. सेकंड थर्ड विजिट यू टेल देम कि these are the problems, these are the complications, this is how we are going to monitor for the complications, this is how you need to monitor on a regular basis. So then we tell them the risks involved. Like for example, if you take care of your diabetes, you will live a healthy life like any other normal individual. If not, then what are the complications? So we do tell them the complications in terms of kidney, eye, heart. These are the important things. Even there are certain other things which we need to tell them. Like for example, sexual dysfunction in diabetics is quite common. but it's not discussed by the patient nor by the doctor. Sometimes we do have to ask these patients.
I mean,
Do you have any system?
some patients would be even shy coming up about
Of
this
course, and
problem.
we need to tell them that it's a
Right.
normal physiological thing.
Right.
So if you have problems, do let us know. And we have to tell them that diabetes control से ये सब चीजें कम हो सकती है, will prevent these problems, including sexual dysfunction. So these are the things which we sort of tell the patients over a period of time, and we have to give them a plan for monitoring. Usually we tell when the patient is diagnosed, may not be at the first visit, but after that maybe second visit or third visit, or in some patients if they agree to, or if they're coming from a long distance, you can do a baseline screening for all the complications. Usually we would do it at the second visit, or sometimes when they're coming from long distance, we tell them this needs to be done. If you want, we can do it at the first visit. So all those screening needs to be done. We need to tell them that these things have to be monitored on a yearly basis. You need to visit an ophthalmologist at least once in a year. And if the ophthalmologist feels that you need more frequent monitoring, just follow the advice. That needs to be told to the
So
patient.
there was a DUCE 2 study that was done for diabetic retinopathy patients. What that said was, if you are just a diabetic patient and your levels are normal, we'll just do an yearly fundus checkup.
Right.
That should be sufficient. Nowadays, we have newer modalities when we take a fundus image, capture an image, print it out, and give a PDF file to the patient as well, just for the record purpose. Okay,
Right.
this is how your fundus is looking.
Right.
Acha, there's no problem. Everything is good, your sugars are fine, come back next year.
Right.
We'll just compare. If something is off, we'll do something about it. If the patient we see कि थोड़ा छोटा मोटा diabetic changes दिख रहे हैं, here and there swelling, fluid leakages, microaneurysms, so then we say every 6 months we'll just keep on capturing the fundus image. Nothing doing yet. Then
Right.
but then we send you back to the endocrinologist.
Right.
I can see changes in the fundus. You need to lower the sugars even further for this patient. On an average, sir, what percentage of patients that you see in your OPD, they are diagnosed with diabetic retinopathy?
I can't come up with the exact number, but I would say it is not too big, but I think the numbers would increase if we screen, if each patient agrees to get screened, because as I told you, we do tell the patients कि आपकी जांच करना ये करना. Many of them would say कि हम हमारे यहाँ जाके करवा लेंगे, and they don't do it. So if all the patients do it, I think the number of patients having the eye problem will be more.
Ideally,
As
sir,
of
it is
now,
actually over 10% of people who have diabetes over a span of 10 years are prone to have diabetic retinopathy of
Agreed.
some other factors. If you are above age of 40,
Right.
the risk factor increases. And
Right, but as you asked me, in my practice, I would say it is less than 5%.
Okay.
The reason again is not
Because you
every
managed to
patient
keep it.
is. No, I wouldn't say. We try to keep it down, but see, if you look at the average glycemic control, which has been seen in our country, only 30 to 35% max, around 30% patients are well controlled. So as to say that their HbA1c is below 7%. So only 30%, 70% are uncontrolled. That is what the scientific data says. And this is not true only for India. Even for developed countries, the number of patients who are well controlled is less. So yes, it has a significant effect in terms of glycemic control. But again, I think more important thing is screening. Screening needs to be done on a bigger scale, especially for things like retinopathy.
But sir, extrapolating from this data that you said 70% of people have a poor glycemic control, we are seeing a rise of patients with diabetic retinopathy problems. पहले, I mean, 5 years ago इतना नहीं दिखता था. Sudden जो rise दिख रहा है, and they are coming. It's very rapidly progressing. The kind of people we are seeing. And they need those anti-VEGF injections, they need lasers. See, these are very costly treatments and a lot of people can't afford them.
Oh yes.
So मैं सबको बोलता हूँ आपको होना ही नहीं चाहिए. Make sure ये होना ही नहीं चाहिए आपको. So नहीं सुनता कोई.
नहीं, absolutely, and sometimes you feel frustrated. I mean, अपने को frustration लगता है कि भाई बताया and तो भी patient is not following, and sometimes you see these patients who have, as you say, minor changes in terms of minor leaks or some exudates. The ophthalmologist has called the patient after 6 months. The patient comes to you after 2 years. 2 साल बाद 3 साल बाद, अरे आपने बीच में टेस्ट कराया कि नहीं साहब, Did you go to your ophthalmologist? नहीं, उन्होंने तो आपको बुलाया था 6 महीने में, नहीं सर हमारा हुआ नहीं. Whatever reasons they give you, I think health needs to be prioritized.
It is seen, sir, कि patients have very poor compliance with ophthalmologists as compared to other branches of medicine. आँख किसको दिख रहा है, चलने दो, वो वाला part है.
See, that is what happens. I mean, when many of the patients ask us कि डॉक्टर साहब ये करने की जरूरत है क्या, मुझे तो अच्छी से दिख रहा है, मैं तो
Exactly.
बारीक अक्षर भी पढ़ सकता हूँ, रोज ये पढ़ लेता हूँ, रोज के काम ये कर लेता हूँ, मुझे तो आँख की कोई तकलीफ नहीं है. तो वी जस्ट टेल देम दैट यदि आपको तकलीफ होने लगी आँख की, इसका मतलब लेट हो गया, इसका मतलब प्रॉब्लम हो गई ऑलरेडी आपको, तभी वो दिखना गड़बड़ होता है. वहां पहुंचने के पहले ही टेस्ट करना जरूरी है ताकि आप वहां तक ना पहुंचे. So these things need to be told to them.
Awareness, I think
Oh yes.
as ophthalmologists we need to do much more awareness than we are already doing.
Actually, I just saw a wonderful video clip on WhatsApp.
Sachin Tendulkar.
Titan Eye
हाँ.
का एक वीडियो क्लिप आया था. Have started an advertisement plus corporate social responsibility program for truck drivers, where in dhabas they have put the menu card in the dhaba as per your Snellen's chart.
अच्छा, आपको ये नहीं दिखता तो
हाँ, पहले मेन्यू आपको करना है, तो आप पढ़ो, वो मेन्यू पढ़ो. एंड कहाँ तक पढ़ सकते हो आप, जहाँ नहीं पढ़ सकते तो then those who cannot read
go to Titan Eye
are
or
seen by the specialists and they are saying there are so many of these truck drivers who are having visual problems or who are driving trucks on the highways, who are at risk for themselves and to the other people around.
A lot
and
of
they have picked up so many of these.
Yes.
That's what was shown on the WhatsApp video clip.
Right.
And it's such a wonderful idea, I think, that I saw. So I think such initiatives, and especially for certain groups in the society, like for example drivers, any driver, be it a truck driver or a cab driver, vision is important.
Very important.
Actually speaking, vision is important for each and every person.
Very true.
And today you tell me, everyone drives. Whatever, he may drive a two-wheeler, he may drive a four-wheeler, but everyone is driving, and if he has a problem with the vision, he is at risk for himself and also a risk for others.
I always say कि आप देख पा रहे हो इसलिए आप पैसा कमा पा रहे हो. Once this goes away.
I have a young receptionist who had a cataract and who was operated just recently. And when she said, I was surprised that she has cataract. And she said, sir, मला यायला गाडी चालवायला, two-wheeler चालवायला त्रास होतो. I told her, will you first fix up an appointment and get your eye operated? Because it is not safe for you, it is not safe for others when you are driving on the street. She got herself operated. But I think we need to, as you said, make people aware.
So, sir, how do you see the future of diabetes care?
I think future of diabetes care is changing.
I mean, AI is coming in.
AI is coming.
Continuous glucose monitoring devices are there.
Yes. In fact, I just came back from our Maharashtra Endocrine Society conference today early morning only. It was at Pune.
Right.
And there were a lot of topics discussed, and one of the topics was AI in endocrinology.
Mm-hmm.
So I think that is coming up in a big way. Artificial intelligence. There are ways for monitoring, there are ways for treatment, and like for example in monitoring, as I already told you, the CGM, which is communicated with the doctors through the app, where you can in real time monitor your patient's blood sugars. There are ways where, like for example, treatment wise, artificial pancreas. Work on artificial pancreas has been going on for decades. And see, artificial pancreas involves three things. One is the sensing mechanism, second is the delivery mechanism, and third is a mechanism which will connect these two. So sensing mechanism was developed in terms of now this CGM and all. Delivery mechanisms have been developed in terms of insulin pumps.
connecting.
How to connect these?
Yeah.
And see, normally in your and my body, whatever our blood sugar is sensed, and based on that, the insulin is produced by the beta cells of the pancreas. So, sensing and regulating this secretion, you need the algorithms. Now, with AI, these algorithms have been developed.
Wow.
And now there are mechanisms where the newer insulin pumps are coming. They will be the artificial pancreas, like artificial pancreas. There are now newer insulin pumps which are there where you can set alarms where blood sugar goes below a particular level, the insulin pump automatically shuts off. If the blood sugar goes above a particular level, it will give alarm to the person that your sugar has gone beyond this, you have to take additional insulin or inform your doctor. So these things are changing.
Also,
Yeah.
sir, nowadays personalized medical therapy kind of newer modalities are coming. CRISPR, you edit out something and you just deliver. This treatment is curated only for myself. It is typed to my gene or something like
Right.
that. You have such kind of newer medicines coming in.
Right, pharmacogenomics is
Yeah.
coming in a big way. There are tailor-made medicines, and actually, this has come in a big way in oncology. We all know, and it is going to be in each and every field, including endocrinology, where like there'll be. You would also know by certain techniques how the patient is going to respond. Many patients do not respond. Same drug works differently in different patients. Why?
How
Because the
so?
response of the individual is different. So I think pharmacogenomics over a period of time is going to give answers to this, and the drugs specific, as you said, individualized targeted therapies would come over a period of time.
Can there ever be, sir? I mean, I don't even know about this. You kind of look at certain markers, and you can then make a prediction. Ki, yaar, if you don't correct a few things, you are
Oh,
going
yes.
to be diabetic very
Oh
soon.
yes, there are. This is where AI is coming into picture, where they are taking into account the family history, and they are doing certain genetic analysis. Also, there are certain genetic conditions which are more common in certain communities, which are being looked at, which predispose them to certain medical conditions, including endocrine conditions. So those things are being looked at, and there will be certain algorithms which are being developed and which will be developed, which will sort of tell you the risk for even like we know that nowadays even calculating the cardiac risks for an individual, there are lots of algorithms which have come. Similarly, there are algorithms for prediction of development of diabetes, type 2 diabetes, and there's a lot of work being done in our country, specifically in south from Chennai. There are centers which are working on these for diabetes prediction and for the risk prediction for development of diabetes.
Uh, where do you see, sir? What hope do you have for the healthcare system in India towards the diabetic epidemic, sir?
I think
Where are things going?
I think it needs significant change. First and foremost thing is it needs to be made affordable, and there has to be proper coordination between the various agencies, including, I mean, the patient, the family, the doctors' clinics, the pharma industry, even social workers. They need to be involved in some of these aspects, and the delivery of the medicines and affordability of the medicines. These are important. That is where I was talking about good generic medicines are required. I am not saying that generic medicines are bad, but you need to have a good control, and a good quality generic medicines are the need of the hour for general diabetic patients in our country, because again, as I mentioned to you, majority of our patients are self-pay patients. Majority of the patients are self-pay patients, and one good thing is now if you look at the pharma industry of our country, they are doing a wonderful job. I mean, good number of these companies, pharma companies, are exporting the
हाँ,
medicines to developed countries,
the
the bulk
kind
exports.
of price for insulin in foreign countries, West world, and the cost of insulin in newer countries, just tremendous difference.
Oh yes, oh yes.
Tremendous.
Insulin, any medication, because especially like you look at in the US, it's all insurance driven. So insurance pays. So the amount, the number of the cost for therapy is very high.
Very high.
And our Indian pharma industry is doing very well in making good quality drugs, and there are a lot of companies which do bulk exports to Europe and to US and other countries where so I think we are looking at a better transformation of healthcare regarding diabetes in our country over a period
Um,
of time.
Moving on to the end of segment, sir. Any advice for young doctors who want to go into the endocrinology side of the field?
Endocrinology is a wonderful field, and endocrinology is very interesting and it is challenging also. Earlier, when we started practice, I think the availability of good assays, the hormonal labs was not there. When we started with the endocrinology practice, RI was the method by which hormonal assays were done. But now, commonly, we have the latest chemiluminescence assays which are available. So, I think the endocrinologists who are coming in practice now have a better available facilities in terms of, because see, endocrinology you need a good lab backup, a
Right,
reliable
right.
lab backup. So now you have good laboratories giving you good results. You need to be aware. I think the most important thing is you need to be aware about the patients, their requirements, and the major chunk of endocrinology today is diabetes. And as we discussed, there are so many challenges regarding diabetes. And another important thing I feel is you need to develop a system in your practice because you can't do everything.
Right,
You
definitely.
just can't do everything even if you want to.
You have to delegate a
So
certain
yeah,
part of
you
things.
but and you need to have a good trained staff. So you need to develop a good team of people working with you, and you need to respect them, regard them, and they are good people who are there working, and they feel also good to serve the patients. So need to have a good team of educators, dietitians, doctors working with you, and proper development of proper system for patient care in every clinic is important, and patient education is very important.
In hindsight, sir, do you think work has become more fun now because so many um, newer gadgets have come out, or new machines have come about?
It is fun,
It does.
definitely. It is fun for first and primary most important reason is because I love endocrinology.
Right,
So it is definitely fun, but there are challenges also.
definitely.
There are challenges which come up over a period of time, and these you sort of over a period of time do take care of those.
If you can pinpoint one most rewarding story of patient care that you remember.
Hmm. Yeah, I would say there's one guy, a young man who, as we were talking about pre-diabetes and all that, very intelligent boy who had got admission in IIT Powai, and his dad brought him over to me because his sugars had started going up, borderline sugars the and all that. So this boy came to me and we were discussing and talking about. Then I told him, well, see, now you have got into the best institution in the country, IIT Powai. You are going to be an engineer from IIT Powai. आप एक साल लेट भी निकले कॉलेज से
कोई
तो भी
फर्क
आप
नहीं
आईआईटी पवई के इंजीनियर रहने वाले हो. You are a brilliant boy, but this brilliance won't be much useful if you are not healthy.
Hmm.
So take care of your health first. It is very important. I don't mind if you take 6 months off, concentrate on your health, or 1 year off, concentrate on your health, and you make sure that you don't progress further. Take care of your health. You will have better quality of life and you will do better in your profession. He came to me after 3 to 6 months and he said, whatever you had discussed with me that time, I took it very seriously. I've changed my lifestyle. I am concentrating more on my health and all. And after a year and a half, I saw this boy. He was completely changed in terms of his lifestyle. His sugars were absolutely normal. He was monitoring them regularly, and he was following a very healthy lifestyle. And I just tell my patients, otherwise also, and this boy also, I told him. And after that, I told him, now you don't need to come to me. Only if you have a problem, you come over. I am here. And I tell my patients also, I am very happy when I close the file and I say that you don't need to come to me, rather than when I tell you you need to come to me every so frequent days. So that was a patient where he took care of himself very well. He took the advice very seriously, and that did help him.
One last question before I let you go. If you weren't a doctor, what career would you have pursued?
That's interesting. In fact, I would like to tell you that my first choice for after my 12th standard was chemical engineering.
Oh,
I would have been a chemical engineer. I don't know what, during that time, I had just in mind that I will become a chemical engineer only and only if I get admission in UD City, Mumbai.
oh,
So that time, during our time after 12th standard, UD City had 2 seats for chemical engineering from Nagpur. And I think I was 4th or 5th, so I did not get chemical engineering. I was getting chemical engineering here in LIT Nagpur, but then I don't know. I had decided then that if I
either there or all or none.
either no. Either I joined UDCT for chemical engineering. If I don't get UDCT chemical engineering, I'll become a doctor. So I don't know why, but that time I wanted to be a chemical engineer from UDCT Mumbai, and I didn't get that. So my father said that if you want, you take admission in LIT in Nagpur, where I was getting it. But then I had said, no. If I don't get UDCT, then I'm going to become a doctor. I'm going to get into medicine. I was getting admission both in engineering as well as in medicine. So that's how I landed up in medicine and became a doctor
Nice.
and an endocrinologist.
Nice. Thank you for being here, sir. It was
Thank
so
you, Sabir.
informative. It was so easy talking to you.
Thank you very much.
We
And
have covered.
I would congratulate you and really appreciate your effort in terms of what we discussed,
Yes, sir.
making people aware about this important aspect of diabetes prevention. And I think this is what is required.
Right,
More
right,
people
right.
being aware. Even if few people just take the thing seriously and change their lifestyle and prevent, it is
going to
rewarding.
make a big change,
It is
sir.
rewarding.
Yes, sir. Thank you so much
Thank
for
you.
coming, sir.
Thank you. Thank you.